Jim, I know you had some questions about this because you've talked to patients who have had problems after FLA, so perhaps you've got a couple of questions for Dr. Karamanian.
Yeah, certainly. Dr. Karamanian, you did a great job of explaining all this to people who really don't know the intricacies, like me being a HIFU guy. But what I'm hearing from a patient's point of view and looking in the blogs is there's a problem with not everybody's like you. And there are people who misread the MRI. And they misread the targeted area, the dark spot. And they treat that. And they miss tissue, and they've missed. I'd like to know from you too. After I'm done here, I have two questions. How often are people retreated because there was tissue missed in the original MRI? Number one. What percentage of patients for these gentlemen, these doctors you worked with, had infections? Because that is another issue. There have been urologists who all of a sudden get this patient in their office who has infection from an FLA, and the person treating him, the FLA doctor, wasn't prepared for the long-term dealing with that patient in their business. There's also been I don't know these for facts, but I've heard complaints of recurrence. And I've also heard concerns about damage to the tissue walls. So these are areas from a patient's point of view that I've personally heard, and I'm not an expert enough to explain it like you are.
No, and I appreciate those questions. I'm going to try to address them one by one, but if I forget one, please do remind me so I address that one as well. So in terms of infection, well, now, if I may, let me make one comment to address a previous question from Mike's a little bit earlier, and tie that into this as well. So I trained under Dr. Walzer at University of Texas Medical Branch, and we do have data that we're looking to publish within, hopefully the next 6 months, that will add, more patients to the knowledge database and the literature. One of the problems that we've had is that it's very hard to the company that makes the laser really hasn't supported it at all in the field of prostate, and so all of the effort and really falls onto us to try to compile all this, and it takes a tremendous amount of work in order to do this in a rigorous manner. So we are looking to get that data published within hopefully the next 6 months or so. So stay tuned. And I'm going to speak to some of our experiences, although the data hasn't been published yet. So I wanted to mention that. So you know where I'm coming from when I address some of your questions. So in terms of infection, we've actually found that with focal laser ablation, there's less of a risk of serious infection than a trust biopsy. I'm not ready to quote exact numbers for you yet, but I think there's a good reason why that is, intuitively. So when you you use a transrectal approach, except for University of Chicago uses a transperineal approach. Everybody else that I'm aware of uses a transrectal approach. Yes, it does use that same transrectal approach that has a risk of infection associated with it. Some of the things we do to minimize those risks are we provide enemas. We have an enema the evening before, the morning of the procedure, dual antibiotic coverage. But fundamentally, one of the main differences with an FLA versus a trust biopsy or a prostate biopsy is that imagine you're taking that tiny laser fiber, inserting it through the rectum into the prostate, and you drag some bacteria with it. Well, what happens when you turn on that laser and it reaches 60 degrees Celsius or higher? Often 60 is sort of one of the cutoffs we use, but usually the temperature gets up to about 80 degrees Celsius. That bacteria won't survive 80 degrees Celsius. Now, what can happen, though, is you can immediately kill that tissue and the bacteria with it, but as the tissue is getting reabsorbed from the body, anytime you have tissue that's not vascularized, that's not viable tissue, it's at risk of getting infected. And so we have seen some delayed infections that come from focal laser ablation. We haven't, in my experience and to my knowledge, I'm not aware of a patient who's needed to be hospitalized for an infection after FLA. It's possible that there's one out there, or it's possible that there are a couple out there that I'm not aware of. But even if there are two, let's say, just making up a number, let's say there are two patients who needed to be hospitalized for an infection after focal laser ablation, that would still put the number less than trust biopsies. Now, there are patients who do, now that's sepsis. That's a patient who has a very serious infection of the after focal laser ablation. There are patients who do develop infections that are less significant than sepsis, and to date, all the ones that I'm aware of have been successfully treated with oral antibiotics. Regarding the practitioner managing a patient who has an infection, I mean, absolutely. The physician who does the procedure should be able to provide that sort of longitudinal care. That's one of the things that is one of the pieces of core training for me as an interventional radiologist, to be able to not just to be a technician, but to see the patient, evaluate them, understand all the different facets of the different treatment modalities, be able to counsel the patient on those in order to explain the risks, benefits, and alternatives of the treatment that we're offering, and then to be able to manage your own complications afterwards. Now, it can become a challenge when, for example, a patient flies back to, let's say a patient comes to Texas, gets treated here, flies back, to the state that they're from. Managing that infection across, a long distance, it would probably be better in those cases for a local physician to prescribe the antibiotics in consultation with the physician who did the procedure. But the physician who did the procedure should definitely be part of the team who's taking care of that patient. And if the patient's local and they're responding appropriately to the antibiotic therapy, then there's no need to get somebody else involved. If, for example, though, there's a serious complication, then, and I'm just speaking in general now, if there is a serious complication, then it's appropriate to bring in physicians of different specialties who can provide advanced subspecialty care. Did I sort of address your questions?
Yeah, you did. I just think there's gaps. I don't want to be too critical here, but you can hear for what professionals tell you, and then you go and see the people's actual comments on multiple sites, and it brings to question long-term credibility. And of course, for HIFU has compromised credibility so far, be long-term, and so does FLA is infancy. But there's also pilot error, and I don't mean to be rude by saying this, but there are guys who just say their doctor screwed up, because there's a very steep learning curve in your business with FLA or HIFU or Da Vinci. So just from my point of view, I'm trying to meander through the parts about this isn't just about you as a professional.
Of course.
This is about your industry laterally. Do these other physicians have the same passion for excellence that you do? And we've already seen, of course, that is compromised in some people's practices. So I just there's too many, like Mike has said, there's too many incomplete things here that make it compelling. I also am troubled by some of these patients that are treated they don't need to be, and that you've already shared that they're good candidates for active surveillance, but they want to just get rid of the cancer. And that's happening with overtreatment in multiple treatments across the country here, which is troubling. But FLA is so controlling for a small spot. How do you deal with a tiny thread that you're going to miss? The MRI that you read, or not you read, somebody else doesn't know how to read the MRI, so they miss a tiny thread of tissue, and they have to get retreated again. How often does that happen?
Well, I can tell you that before, and that's, so let me tie this in as well to another concept, because I think it's very relevant here. MRI-guided procedures should really, in my opinion, be done with those who have advanced training in using advanced imaging modalities to do procedures. And that really is interventional radiologists. And one of the big advantages that an interventional radiologist can bring to the table, who's also a very good prostate imager, is they can look at the MRIs themselves and see subtle nuances that aren't necessarily going to be reported or even seen by somebody who doesn't read a whole lot of prostate MRIs or isn't, very experienced in prostate MRI. And so I take full responsibility. I review every MRI, very carefully before I would consider doing an MRI-guided focal laser ablation on a patient. Believe me, I do not rely on the reports from other physicians before I do this. And it's the same thing before when I would do like a microwave ablation for a liver or a chemoembolization for a liver cancer. You have to review the images yourself and really understand what it is you're seeing, what it is you're treating. There's no substitute for that. And so it's incumbent upon the treating physician to be able to do that.
I agree with all of that, but I think my concern...
Is there any, if I may, is there any discussion going on between the societies about what the skill levels and qualifications should be for people who are practicing this sort of technique? I mean, I realize This is always very complicated, but I mean, in the end, it's the profession that has to take responsibility for the quality of the practice.
Well, so yes and no. It's a little more complicated politically. So, by the way, first of all, there was a meeting yesterday in Chicago that I was happy to be a part of, where some of us who perform MRI-guided focal laser ablation, met and discussed some of the issues that are facing this technology. So, there, I spoke to the company that makes the laser fiber, and I asked one of the representatives if there's somebody who, let's say they've never done a focal laser ablation case before, let's say they've done 2, would you sell them the equipment to do this? And they said yes, they would. For me, that's frustrating, because you want to have quality control there and only allow people who have demonstrated a high skill level in operating to be able to do this. Sadly, as a physician, I've also seen surgeons who operate at low skill levels, hurt a number of patients. Unfortunately, there isn't a good mechanism to be able to prevent people who, who's going to play judge here? How do you begin to set up that sort of regulatory system?
Oh, no, I understand. I mean, it's one of the things I always say to all patients. I mean, every surgeon has to do his first radical prostatectomy, and every interventional radiologist who wants to practice FLA is presumably going to do his first FLA on somebody. This is a constant problem. But I do think, we've there's an obligation on us all to try to help to give guidance as to what is acceptable in terms of the training and the practice using these techniques. Now, I don't want to belabor this because I want to move on. Tony, do you think there is any hope of anybody actually being able to do randomized trials for this sort of thing?
No, I think that Dr. Karamanian pointed out very, very clearly that doing comparative trials from the different modalities that are out there are going to be long-term, they're going to be very expensive, they're going to be very difficult to accomplish. If there's a way to do a clinical trial, I think it could be used well with a subset, like what you call secondary endpoints, would be to go ahead and take a patient who's made a decision that they're going to have surgery, that it's their decision to go ahead and have surgery, and possibly do the procedure ahead of that surgery so that you can gauge what was seen in the MRI versus what was seen in the actual prostate total prostate biopsy. I think the doctor would probably agree with that. And by the way, hi again, Dr. Karamanian. You and I spoke for over an hour about this in early September. Really enjoyed all the paperwork you sent me on this. But that would be my suggestion. If we're going to see a clinical trial on this, it's going to have to go in the direction of maybe a subset trial with which this procedure can be piggybacked onto it to compare the MRI of efficacy versus the actual disease in the prostate. Your thoughts, Doctor?
Oh, I think that's brilliant. I just wish I could get Medtronic to pay for that kind of study. I would love to do that. I mean, I can't even begin to tell you how much I'd love to be able to do that kind of study. The problem is, again, these things are expensive. How do you get? NIH funding has really tightened up these last several years. It's hard to get funding for this kind of study, but I think that would be fantastic. Now, but what's going to happen is you're going to have, even after that kind of study, you're going to say, okay, well, we don't see any clinically significant prostate cancer left, but does that really mean that the patient is going to live longer? Well, again, you still need the 15-year outcome data, and there are still going to be people who criticize it. But there have been some studies that show that where patients who are already going to undergo radical prostatectomy, who did undergo focal laser ablation, but just to test the ablation modality, it did show that there was confluent ablation, confluent cell death in the zone of ablation. And so that's encouraging. The issue then is going to go back to the multifocality question. May I make a few comments about the multifocality question?
Well, I'd love to do that, but we've got one more person. I want to see if she has any questions, and then I want to see if we can get some of the questions in from some of the people on the line.
Sure.
So, Jan, do you have a quick question?
I do. I think for the listeners, patients listening, I think it's important to talk quickly about cost and the fact that this is probably not covered by insurance. So the two ways, if I'm not mistaken, that you can access focal laser ablation or most focal therapies is, number one, paying for it cash. And if I understand correct, is it $20,000 or more, Dr. Karamanian?
Yes, I've seen $20,000 to $32,000 being the range.
Okay. So certainly that's something that you need to understand and ask up front. But the second place would be actually in a clinical trial. And I did look online, and I found 3 right now. One's at NIH, one's at Mayo Clinic, and one's at Indian Wells with Dr. Feller. So I wonder if that's even a safer setting. You would get better monitoring. I don't know, just a thought. But I think it's important to understand it's not covered by insurance, so the way you're going to access it is paying a large amount of cash or finding a clinical trial.
Well, let me comment on that. So first, the NIH trial is with fusion, not MRI guidance.
Okay.
And there are reasons why they're trying to demonstrate this with fusion guidance, but again, I would caution anybody from doing fusion-guided FLA. The outcome data has been bad and with good reason. Then the Indian, by the way, Dr. Feller with Indian Wells, he's definitely doing the most rigorous clinical study on focal laser ablation, where he does an MRI-guided biopsy before and after every patient who's undergoing FLA. But the trial isn't funded, so patients still have to pay out of pocket. And I'm not sure about the Mayo study, but I believe that patients also have to pay out of pocket for that trial as well.
So they should ask, even though it's a trial.
Yes.
They should ask. Okay, that's helpful.
Correct.